This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon practicing in New York and New Jersey.
And I'm Marina Kurian. I'm a general surgeon and a minimally invasive surgeon, and I work in New York City.
Welcome to She's on Call. Today we have a great show regarding global ophthalmology or global eye care, and we're going to be talking with two ophthalmologists and an anesthesiologist about their work on the Flying Eye Hospital, which is super cool. You're going to really like learning about that, and about eye care in general and anesthesia and pediatric anesthesia in particular. So we're really looking forward to welcoming Dr. Hunter Cherwick, Dr. Srini Iyengar, and Dr. Cheryl Gooden in a few minutes.
But first, we have to do our chat. We're going to go through some of the news, which is there any doubt right now that we're in our second wave? Of COVID. Unfortunately, we still have to talk a little bit about it. The U.S. is on just on a surge right now, and this is so many more states are seeing peaks that are greater than they've seen even over the summer. And as you guys know, in New York, New Jersey, Connecticut area, we saw our peaks in March, April, and May, and then started to see decreases. And the rest of the country, on the other hand, had big spikes.
Yeah, we are seeing, unfortunately, maybe even a third wave of COVID, where the numbers are just growing remarkably. We had somewhere between 83,000 and 85,000 new cases reported in the United States on Friday, and another 78,000 on Saturday. There were more new cases on Saturday than any other day of the pandemic in Alaska, Ohio, Oklahoma, Colorado, New Mexico, and Illinois. And it's affecting rural and urban centers, and many hospitals are being overrun. The CDC posted this map on Thursday showing the number of new cases in the past week. And the leaders in the U.S. for new cases at that time were Wisconsin, Illinois, California, Texas, and Florida, with each of those states reporting between 20 and 33,000 new cases.
Yeah, and it's just, there's some talk about, we're just finding these cases because we're testing more. And I don't think that that's accurate at all. What we're seeing is really just how transmissible this virus is, and that we still need to exercise a fair amount of caution, wear masks when we're, around a lot of people. And obviously, Suju's like all about hand washing, so am I, and watching your distance when you're with people that you're in a crowd.
Yeah, because we're not only seeing the new cases, but we're seeing new deaths, right? So we have, unfortunately, the leaderboard in deaths in the United States are California, Texas, and Florida, but 16 other states, most in the Midwest and the Southeast, have had between 100 and 300 deaths this past week. We do have some good news about treatment.
Mm-hmm. And
yeah.
So we had talked last week a little bit about hydroxychloroquine and how that's been shown in multiple studies not to really be of effect. And then I'm going to mess up the name. So doctors find it hard to say these names too, but it's remdesivir was just approved by the FDA prior to, and that's the Gilead makes that, and it was used early on, and we used it in New York area, and it was on emergency use or compassionate use to use that drug. And then now, though, the FDA has approved it for use in patients who have COVID. And Suju, the way it works apparently is it stops the virus from replicating in the body. And the whole question is because some of the studies have shown it to not be effective. But now there's enough other data suggesting that, in fact, it is effective. But, Suju had brought up a great point when we were talking about this, that it may be, when do we give it? It might be timing.
Right. I think it looks like if we give it early on in the course, as the person shows themselves to have a more serious course of disease, we can stop the replication. And the remdesivir in those studies have shown that it cuts the duration of disease from 15 days to 10 or 11 days. And certainly, I don't think we should wait until there's all this organ damage that we can't reverse. But, Marina, prevention remains the name of the game. We have this graph from the Washington Post that shows the mask wearing in different parts of the country. And you can see that in the Northeast, 80 to 90% of people say they wear a mask all the time, 80 to 95% actually. And they have the lowest percentage of knowing somebody with COVID. Whereas in the Midwest and the West, we have the fewest percentage of people wearing masks regularly and the highest percentage of people who say that they know somebody who has had COVID. So we can see that masks really do deter the spread of disease. On Wednesday and Thursday, I walked through Rockefeller Center on my way to work. And on Wednesday, Prometheus, who's by the ice skating rink, which is still a cafe right now, Prometheus was wearing his mask on Wednesday, but on Thursday, his mask was off. Don't be like Prometheus, man. Don't do it. Just keep wearing a mask, washing your hands, and watching your distance.
You're so funny. Maybe when you're washing the mask, right? That could happen.
We should have a second mask, okay?
I'm sure it's pretty hard to get a mask on that dude, as you said. So, we are going to meet our guests in a minute. We have to talk a little bit about Halloween. Halloween, historically, in my family, big deal. I love candy, and I love, trick-or-treating when I was a kid. And for my kids, it's like you can have candy for dinner, whatever. They would go and get treats. And of course, I live in an apartment building, but my candy giving was epic, right? I had nut-free and nut. Things that I had nut. So all the chocolate products we could made in a facility that has nuts. So I would have nut-free and nut, and they'd be separated, and the kids would come back twice. That was a sign of victory for me. I'm like, they're going to come back again. I know it. And so, unfortunately, this year, no trick-or-treating, at least not in our building that was banned. The CDC has actually several guidelines about it. They're recommending that you don't go door to door, and that you although I know that in certain communities they're still allowing it. And what was funny to me anyway, is that I thought Halloween was perfect for COVID because everyone's wearing a mask, and so it would be okay. But unfortunately, it's not. It's because you are getting together with other people, and you need to watch your distance in order to really protect yourself when you're walking around. And that's why they're recommending not to go door to door.
Yeah, I think it's yet another sacrifice of 2020, and the few sacrifices we make this year, I think, will bode well for our recovery from this worldwide pandemic. We are live on all the social media platforms, and we're so excited to see people watching from everywhere. I see Mona Matheson Nanavathi is watching from Zurich, Switzerland. I see Benj Cantors is watching from, I think, his cabin somewhere in the wilds of Illinois. I see people watching. Penny Weissman's watching from Montclair, New Jersey. Nalini Kuke, my aunt, is watching from Maryland. Thank you all for watching. Anup Krishnaswamy is watching from Chicagoland. Please tell your friends that you're watching. We have an incredible show coming up, and we're going to take this opportunity to introduce our guests.
That's right. So we have Dr. Hunter Cheruk joining us. He is the Vice President of Clinical Services for Orbis International, which is the Flying Eye Hospital. Dr. Cheryl Gooden is joining us as well, pediatric anesthesiologist in our neck of the woods at Yale Children's Hospital. And then Dr. Srinivas Iyengar, Srini, is an ophthalmic plastic surgeon. And I think we also call that oculoplastics, you guys. But anyway, San Diego, and he's also part of the Flying Eye Hospital. And we're so thrilled to have all of you guys join us.
Welcome.
Well, certainly it's great to be here.
Yes, thank you.
We're really happy to see you. There is so much that we can talk about, and we're so grateful that the three of you have chosen to spend your Sunday morning with us. Let's just dive right in. So the Flying Hospital is just about the coolest thing I've ever seen. It is literally a jumbo jet equipped with full operating room, recovery room, examination room, wet lab so that budding surgeons can learn techniques, and a conference room. And then it has capability, if you have too many people or more than the conference room can hold, you can set up closed circuit TV and people can be in a tent outside on the tarmac where the Flying Eye Hospital is located in order to take part in the education. So Hunter, and I have to say, I was so lucky to get a tour of the Flying Eye Hospital.
I was going to say, you had to have been on that thing.
Oh my God, it was the coolest. It was at LaGuardia Airport for a while, and Srini alerted me, and the whole family went because you know me, Marina, there is nothing in this world that I have done alone. So my in-laws, my parents, my husband, my children, everybody came, and we had a great tour, and it's really been something that's been
eye-opening? Has it been eye-opening?
Excellent.
Yeah.
So, Hunter, how did this come about? How did this get started?
Sure. One of the founders was an ophthalmologist in the 70s named David Payton from Texas. And this is before the internet, before a lot of people had the ability to do international conferencing. And he wanted to use the plane to show the latest technology and the latest training and go around the world. So since 1982, we've been operating a Flying Eye Hospital. We've been to over 90 countries, and it really is about both skill transfer as well as taking care of the patients. When we land, the only thing we ask of our partners are for stairs, patients who need our help, and doctors, nurses, and anesthesiologists who want to work with us.
So you're grounded right now, though, right?
Correct. And the plane is right now in Texas. Last week, in fact, we just passed our hospital accreditation survey. So the plane is only 20% of what Orbis does. And our telemedicine distance learning platform is booming, experiencing over 300% growth. And so really we've shifted and pivoted to telemedicine and distance learning as well as simulation. So really, Orbis is using this time to highlight other technologies while we're getting the plane ready to go for next year.
We have some pictures that you sent us of the interior of the plane, and I wonder if you can talk us through this. And I just want to tell people, Marina and I both operate at Manhattan Eye and Ear Hospital, and Dada Tuvila, who's one of the head nurses there, is watching. We do a lot of neither Marina nor I do eye surgery, but there is a lot of eye surgery done there. And I think the specialists who are watching would be very curious to see how this setup is done.
Sure. So this is the operating room. This is where Cheryl would be, and that's our teddy bear, Seymour. Every child who's treated is given a teddy bear. That's not only as a comfort aid, but we actually have them put the patch on the eye and take the patch off the next day. So it's almost like a training. You'll see that there's cameras. There's over 6 cameras in the operating room. So the entire team is able to participate and see the surgery. To me, that plane is the best example of functional diplomacy I've ever seen. We have people from all 6 continents working in that plane with local partners. We have a very diverse team. We're kind of like the Flying United Nations for ophthalmology.
It's really spectacular. I mean, that is, even in that shot that you showed, it looks like there's a back window and someone's looking into the room. So you actually are able to watch the surgery or watch the setup. And of course, you're also able to put it remotely so that, as Suju said, they're out tarmac watching. I think there was a picture of that I saw as well, too.
We definitely have a picture of the exam room. So maybe we'll shift gears to Srini and ask you, how'd you get involved with Orbis? What do you find doing work with Orbis and other groups where you do humanitarian eye care?
So Orbis, I've been very fortunate that I got to get exposed to Orbis as a resident, which, many residents that are in ophthalmology don't get a chance to learn about Orbis or spend time with them. So I spent time as an associate ophthalmologist And Orbis is nice because it allows people to participate at different levels of training, both as a resident, as a fellow, or as an attending or a volunteer faculty member, which is what I do now. And so I've been very fortunate to participate at different stages. And so most recently, we were in Ghana, but each of those roles, you have different tasks and responsibilities. And so what's nice is I've been able to see that because of a faculty member who first introduced me to it.
So we have a picture of the exam room. I wonder, can you tell us what happens in here, Srini?
Yeah. So this is great. So this is actually just anterior to the operating room for for the medical people there, and so you can actually see back into the operating room in the back windows. And this part is where we see the post-operative patients the next day. It's also all these machines. You see lasers there that are responsible for preventable blindness for different parts of the world. And you also see there in the middle, you can kind of see, if you look there's a simulator. And this is one of the coolest things, is a lot of the surgical skills can be learned on a simulator. And Orbis is very big in simulation. And recently is applying for different grants, being able to use simulation technology to help developing surgeons.
That is really great. That is the brightest eye exam room that I've ever seen. Because when we all get our eyes checked, you go in and it's almost like a darker room, already, and then they do it. But I know that was just for the photos, but it's just funny. But you can see all the equipment that you might see at your own ophthalmologist's office, or occasionally, at the eyeglass store. And you do it with the optometrist. Hey, can you explain the difference between ophthalmologists and optometrists for our viewers?
So either one. I can take this one. So ophthalmologists, optometrists spent 4 years after college doing optometry school, which is focused purely on the refractive elements of the eye, which is, glasses primarily. Ophthalmologists go to medical school, so it's 4 years of medical school, 4 years of residency training, followed by fellowships. And so we'll get into some of the specialties here shortly, but some of the specialties maybe 1 or 2 years in more advanced training. So ophthalmology, it's a big difference in terms of the medical and surgical treatment of eye disease versus the addressment of refractive errors, which is, we kind of call refractive errors, but it's being nearsighted or farsighted.
That's terrific. In otolaryngology, which we all used to be together, right? It used to be EENT. So, and then we decided that we couldn't understand eyes, so we got rid of you guys. But we have this.
You guys don't know this, but if you ever, as a physician, and Cheryl, you certainly can speak to this too, and sometimes you need to look at all the consults. Eye consults you can't understand. Everything is it's a different language. It's like shorthand.
It's like a V and then some numbers.
Yeah.
Next to it. I don't know what that means. It means the eye doctor saw the patient.
Yeah. We're thankful.
Cheryl, as we talk about global ophthalmology, we can't do anything without incredible anesthesia support. And as Hunter and Srini were saying, they're all about simulation and about teaching with simulators, so that once the person goes into healthcare with a patient, they've had some experience. Can you talk to us about your experience with Orbis and the strengths that you have brought and the strengths that you've found there?
Absolutely. I've had the pleasure to go on several missions with Orbis, and I must say it's an amazing experience, not only working on the hospital on the plane, but we also do work locally. So it's a nice mix I've found over time. What I can say is that simulation certainly plays a role in anesthesia, and part of that gets incorporated into what I do when I go on missions. And I can certainly speak to the Orbis mission, where I've had the opportunity to not only teach PALS through simulation. I think
just explain, it's pediatric advanced life support, which is so important.
Yes, it is the PALS. That's absolutely right. And what's even more exciting about the fact with PALS is that the latest guidelines were just released last week.
So everybody was working during the quarantine. Updating guidelines, and you guys creating sim models. It's really, I feel like I didn't do anything.
Absolutely. It was a busy time, certainly. I had the pleasure of working on the 2015 guidelines for PALS, for Pediatric Advanced Life Support, and the 2020 guidelines came out with a couple updates, but pretty much the same. And we can cover a little bit of that later. But going back to Orbis itself, as you saw from the photos, the operating room is quite similar to what we have here in the U.S. Certainly the anesthesia machine that I'm using is exactly the same as that I would use here at Yale or any other facility, basically, that I've worked in the U.S. So safety being our priority, the equipment is top-notch. The supplies that we have available to us are no different than what we would use here in the U.S. So it's a very good opportunity for learning and sharing the experience with not only trainees who sometimes come along with me on missions, but certainly the locals.
So, we see this beautifully decked out operating room. You and I have been on medical missions and surgical missions to Nicaragua. And, the situation can be very different there. Up in the hills, we've actually had to set up our own operating room. Can you tell our listeners and our viewers, because we're also on WBAI 99.5 FM and WBAI.org worldwide on Mondays from 2 to 3 p.m. Eastern and Tuesdays from 5 to 6 a.m. Eastern. We're very grateful to our radio listeners as well. But can you talk to us about what it's like coming from a very well-equipped American hospital to try to set up something where the resources may be not as good?
So obviously it does present some challenges for us, but what I can say over time, and Sujana, you and I have, as you mentioned, we've been on the missions in Nicaragua. It does create challenges, but certainly at the end of the day, it's all about safety. As you can see in some of the photos here, I'm actually intubating with locals, and I've brought some equipment with me. For example, video laryngoscopy is one of the devices that can be used for intubating patients. Certainly, we keep in mind the fact that these types of equipment may not be available in the local institutions that we're working. So we keep all of that in mind. The experience, it's basically to broaden their overall knowledge of what's out there. But certainly I do like using what the locals have so that they can learn to use their equipment and opportunities in a much different way.
Okay, you guys, we're live on Facebook right now, YouTube, which is closed captioned. Suju is always great about pointing that out. And then we're on LinkedIn and Twitter. And if you are enjoying our conversation or you want to share the information with your friends, just like and tag your friends so that they actually get this information as well. How cool is it that we get to talk to people? One, so much humanitarian work over here. All four of them have done missions. And also this cool flying hospital. It's so just wonderful. Now, some of the things that you guys are going to different parts of the world to treat are actually things that could be very simply treated if the resources were there. So can we talk about some of the diseases that you are addressing when you go there? So, one of it is that 1 in 7 people live with avoidable vision loss or blindness, which I think is worldwide is a terrible situation, and clearly something that if we can intervene early would be even better.
Yes, that's a great point. And 90% of the world's avoidable blindness is in low to middle income countries. So a lot of these patients are getting the double hits of poverty and blindness. And that's where Orbis steps in to break that vicious cycle and turn it into a virtuous cycle so a child like this can go back to school. I think you can see that in this patient's right eye, the black pupil is now white. And that is because the clear lens that focuses the light coming to the back of the eye has become opacified. We can now very carefully remove that lens, put a new plastic lens back in its place so there's focusing. And this is where we need Cheryl, because this child's going to need to go to sleep so that we can do this very safely. The child won't move. But grandparents or parents who are having cataract surgery can do this while they're awake, just using topical anesthesia. So cataract is the leading cause of blindness. It can be treated both in children and adults. And this is one of the most common things that Orbis trains and does both in children and adults. And we really have been using simulation now to drive this training globally.
And then I'm wondering, Srini, if you can talk to us a little bit about glaucoma and what happens with that.
Yeah, so glaucoma is one of the most common causes of blindness worldwide. And the challenge with glaucoma is really the screening. There's a lot of people who have glaucoma and they don't know they have glaucoma. And, glaucoma is actually a spectrum of diseases. Traditionally, we think of glaucoma as having eye pressure in the eye, kind of like having high blood pressure in the body. And it's something that, is measured by your eye doctor. And so it's not something that you feel or you're symptomatic from until it's too late. And so when you look at this slide, you can actually see kind of how glaucoma progresses. And the challenge with glaucoma is it doesn't affect your central vision until late. So you can see it's your peripheral vision that slowly starts to disappear until the central vision is affected. Unfortunately, it's an irreversible cause of blindness. And so all the therapies used in the treatment of glaucoma are really to hold back the progression. And so it's one of the things where, the challenge is really getting the screening done and then implementing the surgical skills and technologies around the world to stop this blinding disease.
Thank you. Hunter, diabetes is a huge problem worldwide. Can you tell us what happens to the eye in diabetes?
Sure, and that's a great question. This is one of the leading causes of blindness. If you see in the back of the eye, the diagram that you have in the middle has those blood vessels. Well, as we all know, diabetes is high sugar, and it damages those blood vessels where the film of the camera, the back of the eye, the retina, gets damaged because it's no longer getting the correct blood supply. And so now the good news is we can treat that with lasers, medicines. The entire care for diabetic eye disease or diabetic retinopathy has been revolutionized since I finished my training. And we're now globalizing that treatment at Orbis. We now have artificial intelligence. We are doing teleconsultations. So the good news, and what I want all your listeners to know and all your viewers to know, if you have diabetes, please get regular eye exams. A stitch in time can save 9.
I think Marina's trying to ask a question, but I think something happened. I probably muted her because, I'm jealous. But
can you guys hear me now?
Yes, go right ahead.
I'm trying to ask a few questions. Can we just go back to that cataract slide? Because
yes.
I want to say that, the child, if early on, you might not see it, but if you take a photo of a child, right, and you see something's different in the eyes, there are other things that you can actually find, there's a tumor that you can find like that the eye will have a difference when you shoot a picture of it. And a lot of times in these developing countries, they don't have the ability to take these photos. Like you show this and you could see that the difference is there. But sometimes when you're looking at someone or the light is a little bit off, you may not actually see it. And so what we do when the babies are born, right? They flash a light in the eyes to make sure there's not a congenital cataract, things like that. There's so much preventive stuff that we do from when the child is born that isn't there in these other countries. Can you guys speak to that?
You're exactly right. In fact, I tell any parent, if you see white in the black pupil, you need to see that child or get that child referred immediately to a pediatric ophthalmologist. And you are right. It could be a cataract. There's an ocular tumor called retinoblastoma. Orbis is a world leader in this. We have over 950 cases around the world being managed through telemedicine for this disease. So you're exactly right. And as opposed to an adult cataract that can wait for it to get ripe or more mature or more dense, you want to operate on a child as quickly as possible because the child's visual pathways are still developing in their first few years of life. And if there's an opacity or a blockage of that clear light coming to the back of the eye, they will get the lazy eye or the amblyopia. So you are exactly right. If you ever see a white pupil in a child or the red reflex on the camera, on the picture does not look red, you should definitely speak to your pediatrician or your eye care provider about that. Thank you so much for bringing that up.
Yeah,
it's a really great point. Thank you. Cheryl, when you're putting these kids to sleep, sometimes kids are fighting as they go to sleep. They're fighting as they wake up. How, that's, the eye is so delicate. What are you doing in your field to enhance the outcomes for these children?
Certainly. So there are a couple of things that we do initially in the pre-assessment phase. So prior to bringing the child into the operating room, I'm trying to decide whether they need a pre-medication. So pre-med is an option. It's an oral medication that can be safely provided to the child. And it's a limited amount of volume. So they get that, and it takes effect in probably 10, 15 minutes. They can go into the operating room a lot calmer, relaxed. That's one way of getting a child into the operating room. Another way is to actually allow a parent to come in. Obviously, we've been impacted by the ability of parents coming into operating rooms with COVID, but generally speaking, we do allow a parent, when possible, to come in to just kind of help the child transition from being awake to going off to sleep, and then the parent leaves the operating room. That can help to smooth out the overall induction, putting the child to sleep.
So, Cheryl, I used to want to be a pediatric surgeon before I became a minimally invasive surgeon. So I remember that if we had a patient that was going to the OR, sometimes we'd give them something like chloral hydrate, or if they were going for an exam that they, needed to be a little bit calmer. Do you guys use that? And also, there were these lollipops that you would give the kids to try and pre-medicate them, right? How cool is that? The kid, it's also like you're duping the child, but still. It's kind of nice.
Yeah, I think these days we tend to use more midazolam. So an oral medication, sometimes we'll even give an intranasal dose of a medication such as midazolam or even dexmedetomidine, also known as Precedex, helps to provide a degree of sedation. There are even situations where we will give IM injections of ketamine, for example.
So IM, Cheryl, means what?
So, intramuscular. Thank you, Sujana. So an intramuscular injection of a medication called ketamine can also help in the process of being able to bring a child into the operating room.
It's so important for them to be calm and just to, back in the day, I was at Boston Children's.
Sure.
And I was also at Wayne State, and all of the care around that in terms of the child health or child life services, I think it's called, right? They come in and really try to make everything as comfortable for the children because, they can sometimes need multiple surgeries, and even children can have PTSD or post-traumatic stress disorder. We never talk about it with our patients, but I've noticed in a few of my patients, because they've had to have 2 or 3 surgeries, I'm like, are you having any PTSD about coming into the hospital? Because it can be actually so scary. And so there's a lot of effort that goes with surgery for kids, as you all know, to try and prevent that anxiety. And so we're so glad that we have you here, Cheryl, to talk about it. Things that we try to do to help those kids.
Yes, and you're absolutely right about child life services. They definitely add an element where they have distraction techniques, as we like to refer to it, and they can certainly help that child in coming into the operating room. You did mention chloral hydrate. I just want to take a moment to talk about chloral hydrate. Not used as much these days. We saw a significant amount of sedation, so sleepiness, associated with that drug. So I have to admit that it's one drug that we tend not to use these days.
Yeah. Also, I trained so long ago, Cheryl.
Your chloral hydrate is showing, Marina. That's all I can Let's go back to some eye diseases if we can. We talked about diabetic retinopathy, but and we talked about the eye findings in childhood cataracts and certainly tumors of the eye. But there's a retinopathy of prematurity that's really interesting to me. Last week we had a neonatologist on our show, and we talked about these very, very early births, these children who are born at 24, 25, 26 weeks of gestation, whom we have the ability to keep alive and allow them to live and to thrive. But now we're seeing the problems in many organ systems associated with this. And I think one of these problems is vision. So I wonder, Srini, if you can, or Hunter, if you can, no, I think it's Srini, because I think Hunter answered the last one. So Srini, can you talk about this one a bit?
Yeah, so this is great. So this photo actually, retinopathy of prematurity, that's exactly right, Saju. It involves, children who are born below 32 weeks or, around 3 pounds. When they're born that early, the retina hasn't completely developed. And so if you start with the eye diagram there, in the terms of the basics of how the eye works, you can see the pupil that's labeled there, and the light comes through the pupil and it's hits the cornea, first it hits the cornea, then the lens, and it bends the light to hit the retina. And the retina is kind of like the film in your camera, and that's where the conversion between light gets changed to an electrical signal that goes to your brain. And it's sort of like wallpaper, is what I tell patients, is that the back of the eye, the retina is like wallpaper, and it can slowly pull away if you have problems. And in this case of retinopathy of prematurity, you can have parts of the retina that haven't been completely vascularized or haven't gotten a blood supply quite yet. And then they start to grow these abnormal vessels, which pulls on the retina, kind of like pulling wallpaper off your eye. And that's kind of the term retinal detachment that you've heard before. And that can be a potentially blinding issue that's permanent. And so what retinopathy of prematurity is preventing those bad blood vessels from forming and that traction developing, pulling the retina off. And so what you see in some of these photos is, in fact, on the left there, that's one of the famed Orbis volunteers who's volunteered for a long time. She's a retina specialist from Dartmouth who's looking at a baby there, examining whether or not that child needs a laser therapy or an injection of medication inside the eye to stop the progression of this disease. And so the challenge in a lot of these places that, Orbis works in is the first step is screening. So making sure that children who are born, preterm, less than 32 weeks, or in the 3 pounds, that age, that they're getting regular screening to avoid the development of a retinal detachment, because that's something that's, once you get to that point where the retina is pulled off the back of the eye, then the potential to improve that is limited.
That's this is specifically for prematurity, and it's not because of the prematurity and the oxygen, right? That's different. That causes something like a cataract. This is just really the kid's eyes are just not growing properly. It's so apparently you guys sent us a fact that it's more prevalent in Latin America and Southeast Asia. And why is that? Why do you think? Is that also because of the screening?
Yeah, I think Hunter could address that in terms of the screening in Latin America.
Yeah, so I think this is a disease caused by oxygen, and a lot of these children are born early and put in neonatal intensive care units, but they don't have the monitoring or the ability to blend the oxygen. And this is exactly what Cheryl does, making sure these children's lungs are okay. Well, as you put too much oxygen in the eye or in the body, it can damage those very sensitive blood vessels in the back of the eye. So what we've seen is an epidemic where these children are now surviving early birth, but their neonatal intensive care units cannot do the monitoring to adjust the oxygen saturation on the ventilators so that they're getting 100% oxygen, and the eyes are being damaged because of this. So that's why Cheryl is so important to what we do at Orbis. It takes a village to get their child their eyesight, and it takes training the anesthesiologists, the nurses, the biomedical engineers. We have 2 full-time biomedical engineers on the plane who do nothing but teach about ventilators and all of these things. So in a lot of ways, a lot of low to middle income countries have become victims of their own success, where now children are surviving early delivery, but they don't have the technologies that we've now developed over the last 30 or 40 years here in the US to control those oxygen levels. And that's something now we're training. So we do very robust training programs for anesthesiologists, neonatologists, as well as the nurses. And this year 2020, is the year of the nurse. And I can tell you, it's the nurses who are driving the care in these neonatal intensive care units. So they are a big focus of our training and our support for pediatric ophthalmology.
Where would we be, right, without our dedicated nurses? I mean, really, not only do they have the leading edge, but they have the personal touch, the actual patient contact that is so ongoing. That's amazing. I remember one of my trips to Nicaragua, there was an incubator there, but nobody knew how to use it. So there's no point in providing stuff if you're not teaching. And I think what you said about biomedical engineers working alongside physicians and nurses and techs, this is where we advance healthcare. Let's move on to trachoma. Trachoma disease, which is a bacterial infection of the outer eye, but that can lead to trichiasis, where the eyelashes scrape the cornea and cause blindness. Ooh. So, Hunter, do you think you can talk to us about that?
Absolutely. And this disease was everywhere in the world. It was in Ireland until the 50s. And that's why Orbis Ireland is helping our partners in Ethiopia deal with the epidemic they have now. So the bacteria is transmitted by flies and unsanitary conditions. And over time, the eyelids scar as that bacteria heals. And now your eyelashes become like a broken windshield wiper and start scratching that clear cornea. It's one of the most painful causes of blindness. And it's something that's completely curable. So at Orbis every year, we distribute over $200 million worth of the antibiotic Zithromax. So I'm sure many of you and many of your viewers and listeners have taken a Z-Pack for an upper respiratory cold or sore throat. We now use that to treat the same bacteria that's affecting the people who live along the Ethiopian border of the South region and preventing this disease. And I'm really, really excited to see the tremendous impact we're having in public health, that we're using this not only now to teach about trachoma, but also hand washing for COVID. And we're using the same network, the same backbone we use for supply chain and antibiotic distribution to talk about masks, social distancing. So really, I'm very, very proud of our team in Ethiopia. I know the plane gets a lot of credit at Orbis, but we have 70 full-time employees in Ethiopia who their life purpose is removing this horrible disease from their country. So this is a disease that I think we're going to remove very quickly from Ethiopia and the world in my lifetime. And that's a huge accomplishment, just like we've done with smallpox and other diseases.
Yeah, Africa just eradicated polio. I mean,
that's exactly right.
We can do it if we set our minds to it.
Well, and this is just there's never been a better time to be alive or be in medicine. And the technologies we have at our fingertips, I mean, what we can do with iPhones and the technologies, it's just stunning. And, the other day, one of our pediatric ophthalmologists was supporting one of the doctors real time in the operating room in Mongolia. This is a doctor where he's been many times back and forth. And you're sitting there thinking that this is nothing I thought possible that would be in my lifetime. When I was going through medical school and ophthalmology training, gene therapy was more phi than psi. It wasn't something I thought would be possible. Well, the FDA just approved the first ever gene therapy for an eye disease. The first ever artificial intelligence was approved by the FDA for an eye disease. So for me, it's just such an exciting time to be an ophthalmologist as we look to globalize these technologies and get people early diagnosis, better treatment. And to me, that's why I'm so excited and so passionate about the work that Orbis does.
I share your passion. You can see it. Everyone can hear it, and they can hear it on WBAI tomorrow at 99.5. And you guys who are watching, again, we are live on Facebook, YouTube, and LinkedIn, as well as Twitter. And if you like what you're hearing, tag your friends. And also we do replay. And so we'll be, our show will be up again. I want to switch gears a little bit and talk about some of the surgeries that you guys do when you're traveling. Can we talk about strabismus? And one of you guys mentioned amblyopia before. Can we just talk about the difference and also just, explain what strabismus is?
Right. So there's two terms there. There's strabismus and there's amblyopia. So strabismus basically means a misalignment of the eyes. And so in children, the most common type is where the eyes turn in. And the technical term is esotropia when the eyes turn in, and exotropia when the eyes turn out. And so Orbis is really committed to pediatric reducing preventable blindness in children, and strabismus can lead to amblyopia. So what that means is, if your eyes are pointed directly like this and one eye turns a little bit to the left, over time, the brain tends to focus on the eye that's focused straight ahead and starts to ignore the eye that's turning out. And so what can happen there is those neuronal connections don't form, and those eyes that aren't aligned properly can develop amblyopia or blindness. So the term amblyopia, what that really means is that the eye itself is anatomically okay, but those neuronal connections where it's connected to the brain aren't developed. And that's something that, we're not quite to the point where we can fix amblyopia. One of the things we do to reduce it is, as we talked about on the slide, is patching the good eye. And so what that does is if one eye is weaker, in amblyopia, we also see that where the prescription is different. So if you see someone that they're born and one eye, their prescription is really different between the two, the brain tends to focus on and use the eye that's much stronger. And so by patching the stronger eye, you get the brain to really develop those neuronal connections to the weaker eye as well. And so that's something that there's a critical time period in children when you want to do it before the ages of 9 or 10, because by then those neuronal connections have formed, and blindness it's a functional form of blindness where they still have an eye, but the eye itself isn't really working. And so eyeglasses, trying to make sure that the prescription is equal on both sides, so that, or not equal, but perfect on both sides, so that the child has good vision in both eyes, will make the brain not favor one eye and cause amblyopia. Surgery is formed early in these childs. Some of the surgeries that we do on Orbis when the youngest patients is for strabismus. And so one of the pediatric ophthalmologists, that Hunter was talking about earlier, he's operating on children within their first year of life where their eyes turn in. And so the children who come in for strabismus surgery, that, in my experience, those are really the most exciting patients that we see on Orbis, especially on the Orbis plane. When we see a child that, in some of these places that was never been on a plane before, they probably won't be on another plane. But for them to come on the plane, have this surgery, and then walk off is really kind of amazing.
I think you guys may have the coolest plane. I've never been on Air Force One, but I feel like this plane is, the coolest plane. Like after that, when you just see a 5-row of seats, you're like, yeah, no, this is not.
So, we did talk about using simulation for eye surgeons. And then Cheryl, I know that you've used simulation to help anesthesiologists and anesthesiology nurses learn what to do. So, and you did talk about PALS, which is Pediatric Airway Lifeway, pediatric. Oh heavens! You're going to tell me what PALS is.
Yes, I'll tell you what it is. Yeah. So PALS, so Pediatric Advanced Life Support. So that's the advanced form, and there's Pediatric Basic Life Support, BLS. So the guidelines were just updated. Actually, the newest guidelines came out last week. So it's been an exciting time for the American Heart Association. I am a pediatric anesthesiologist as well, and I've been able to incorporate my PALS knowledge and experience from over the years as an instructor into what I do, not only in the operating room setting with trainees, but also, as you mentioned, with nurses. So at the level of pediatric advanced life support, that's really referring to the first responder or those who work in the hospital setting, healthcare providers. Those who are basic life support responders can be lay personnel. So lay persons can get involved with this. And it's really important to learn the skills of it. So I see here on our graphics, we have on the left, how do you provide compressions? And an important thing to know about life support in general is compressions are key to keeping someone alive. Certainly breaths to the airway can certainly help, but the studies have shown that if you do compressions only, you can certainly help to save a life. So there are two mechanisms for providing compressions in infants. As you can see, there is the encircling technique. So it's a 2-thumb encircling hands compression. And the rate that is applied is generally 30 compressions, followed by 2 breaths if you decide to provide those breaths. And again, I'm referring to the lay person.
Cheryl, I want to ask you, in adults, right, when we do this, we have to do it to staying alive, right? You're supposed to,
correct.
That's the beat that you do. Is there a beat for the kids' compressions or?
Pretty much use the same. Staying alive is a great way, particularly for lay persons, to be able to keep up with the rate and depth of compressions. So it's a nice tune. And once you get into the compressions, you just keep doing it along to the music. So that's actually a great way to remember. The other technique is the 2-finger compressions, and that's for infants. When we move to the child, you can see it's more of a hand compression. You can use one hand, or you can do a 2-handed technique, and making sure that it's all about being fast, and also the depth of the compression is important. So basically what we want to keep in mind is that at least 100 compressions is the minimum that we want. And research has shown that we should kind of max out at about 120 compressions per minute. That is the most effective. So again, to emphasize, yes.
It's also so important, right, to make sure that, like, when you come up, whatever you're watching with this child, to make sure that their airway is clear, right? That's like, you have to do a finger sweep and things like that. And it's not just the compressions, like, because there's some reason that the poor child went down.
Yes. So first, when you come on any scene, you want to make sure that it's safe for you as the rescuer to start observing and looking at the child. So that means looking at, are they breathing? Do they have a pulse? And that can be checked by doing a carotid check, so along the neck, or you can do at the wrist, what's referred to as radial. So once you've determined that the child is unresponsive, you want to start compressions immediately. I must say the finger sweep is something that you can think about doing later on, but it's important to start with the compressions, because we know that compressions is what we need to drive the blood pressure, to drive the blood along, to improve the overall cardiac output, as we refer to it. So the blood that's getting to the heart and circulating around the body. So it's really about that. You can do a further sweep and look into the mouth once you have more responders around to help with that. But what I want to emphasize is that it is truly about the compressions. And if you want to give breaths, that's a great thing too.
Thank you so much, Cheryl. I think it's such a fear to have your own baby or come across a baby or a child who's in distress. And I think the more we distribute this information, the better. We are almost out of time. We have about 7 minutes left. So there are some questions that came in. One of the questions is, does patching, Danette Mojica says, does patching the good eye cause increased headaches in children? And we're going to do this sort of as a lightning round. So Hunter, are we giving kids headaches?
Well, I think she should see the doctor who prescribed and let them know about the headaches. Headaches are not the most common thing people describe or have as a complaint from patching. Usually it's the children want to tear the patch off because they want to see out of the better seeing eye. The patching is very important. You really want to intervene during that critical development window. Trying to patch after the 12th birthday really does not have strong impact as doing it at the time. So if there are challenges, headaches, or the child complains about anything with regards to patching, I would speak to the prescribing physician, but really the compliance is critical to intervene and give that child the best chance of maximizing their visual potential. I know it's difficult, but it's important to do that.
There's another question we have about, can lazy eye be corrected in the adult? And Srini, maybe I'll have you take that.
Yeah, so the term lazy eye really refers to many things. People use that as a general term, they use it for ptosis, where somebody has a droopy eyelid, or amblyopia, where the eye hasn't developed, or they use it for strabismus, what we talked about, where the eye is misaligned. So when the eye is misaligned, in the case of strabismus, the adult can still, we can still do surgery to realign the eye. Amblyopia, on the other hand, is something that we can't fix as an adult. So it's kind of like once those neuronal connections pass the age of 11 or 12, like Hunter was talking about, when we get past that, then unfortunately as an adult, we don't have really treatments to fix that.
And there's a last question, Srini or Hunter, and it's about the risk of detachment after retinal detachment has already occurred and you fixed it. What's the likelihood that can come back?
Yeah, and I think that's what caused the first detachment and what was the surgery. And that's something I would discuss with your surgeon who did the surgery. I would say anyone who's had a retina problem should, for the rest of their life, get a dilated or a full retina exam at least once a year. And if they have any symptoms of a retinal detachment where, like Srini said, the wallpaper's coming off the wall, so if there's a shade in their peripheral vision, if they see a bunch of flashing lights or a bunch of new big floaters, they should immediately speak to their eye health professional. So I can't give a specific answer for percentage chance of it reoccurring for this patient because I don't know their case, but I really strongly encourage them to keep both eyes regularly seen by a specialist at least once a year.
That's terrific. I think we're going to switch to maybe the more common or something a little bit different for the moment. Srini, you do oculoplastics or ophthalmic plastic surgery. And can we talk a little bit about blepharoplasty and maybe dacryocystitis, things that people might feel that they need to see you for?
Right. So it's a specialty within ophthalmology. First, kind of like, like Marina was saying, it's also known as oculoplastics. And that's a specialty within eye surgery or ophthalmology where we treat things around the eye, including the eyelids, the eye socket. And so you can see one of the cool things about Orbis and some of these programs abroad is that oculoplastics doesn't really require a lot of technology. And so here on the pictures you see are patients who really have, in the United States, that we see with droopy eyelids or bags underneath their eyes. The woman on the right, she's a 90-year-old who came in, she can't really see because her eyelids are so droopy on the upper lids. And then you can see on the lower eyelids, that's more of an aesthetic procedure that oculoplastic surgeons also perform to address the bags underneath her eyes. And so that's kind of what oculoplastics is. Dacryocystitis, on the other hand, is, something that, this is a patient who has long-standing tearing. So if you have tearing and your eyes watering on one side, it may be an issue where the plumbing of the eyelid isn't working well. And if you don't get that addressed, you can develop into an infection. And so that's what she has on the upper eyelid there, or on the upper picture. And once she's treated with surgery, which is kind of like a bypass that we do in her heart, except for the tear duct, then that resolves.
That was a dramatic eye picture, man. like you can see, I get one little thing and I'm already calling the doctor. I mean, I don't know, did that happen overnight? Because that's, Let's pick up the phone and give somebody a call.
Well, it progresses, right? So when somebody has a blockage in there, it's kind of like if you have a blockage beneath your sink, over time, it starts to smell, it starts to get worse. And so you want to address it sooner than later. And so, so it does take time to develop that. But seeing an ophthalmologist or an oculoplastic surgeon for that is important.
And just as PSA, how often are you supposed to see an ophthalmologist or have your eyes checked?
Right. So, that's it was going to be one of the, three things that you wanted me to mention at the end is, depending on where you live, I think, if you have access to eye care, there's no reason why you shouldn't have an eye exam at least, once a year, if not every 2 years. But because a lot of the times what's really amazing about ophthalmology is that we scan people not only for eye disease, but looking in the eye, we can see people and diagnose people with diseases they may not know. Just recently, we have a free clinic here in the United States, in San Diego. I had a medical student watching me examine a patient's eye, and I was able to tell them that they had diabetes without knowing that they had diabetes. And so these are things that we can catch through an eye exam. So I would say, every 1 to 2 years is certainly reasonable.
And Hunter, do you have a parting word or two? We've got such little time, and you guys are so amazing guests.
Well, I just appreciate you all letting us talk about Orbis and our work. And the most important thing is you connected us with Cheryl. I haven't seen her because of the COVID pandemic. You don't realize how much she's done and contributed to the field of pediatric anesthesia. She's literally written the book. So, and being able to work with her is just fantastic. I wish she and I could be on the plane right now, but it's just good at least to be together here on the TV show, because she really is one of the best. So thank you for reconnecting us.
That's what we do. We just bring people back together. We love it.
Yeah.
Any final thoughts?
Great to see you. So no, I totally agree, Hunter. It's great. Our first mission together, as I recall, was in Tanzania. So certainly my parting words would be, doing good is a good thing. So volunteering and Orbis is a great way to do it, and certainly consider it. There's so many things that you can do as a volunteer, whether it's with Orbis or other organizations, but certainly my passion has been with Orbis.
Hey, one thing, there has to be a way to donate to Orbis, is there?
Certainly, if you want to learn more about Orbis and the work we do, go to orbis.org. You can learn all about our patients, our countries, our programs, our technologies. So obviously, I want to invite you all out to the plane, and we got to get everyone, especially Cheryl, to teach a simulation and teach you all pediatric advanced life support on the mannequins and the training simulations we have. But yeah, if you want to learn more about Orbis, please go to our website. I just want to thank you for your interest in our mission. Like I said, it's a huge, rewarding field to be able to give someone their sight back, especially when they're in a low to middle income country and you've given them hope for the first time. That is just an incredibly powerful thing to be part of.
I want to thank you guys so much for joining us, and thank our viewers as well. We want to give a shout out to our production team, because without them, we would not be able to put this on. And these are our producers and the people that really make this show happen. And then next week, we'll be back, and we have a great show lined up. Suju?
So next week is going to be the great showdown between ENT and bariatric surgery, because we've got an otolaryngologist, Dr. Maria Cerna, who's going to be talking about sleep apnea. And we have a bariatric surgeon, Dr. Emma Patterson, who's going to be talking about that. And I'm an otolaryngologist, and Marina's a bariatric surgeon. So we're going to have the showdown of all showdowns. And we want to thank you so much, Hunter, Srini, and Cheryl, for spending this hour with us. And thank you to our viewers and our listeners. See you next week.
Bye.